So, good evening, everyone. So, we are going to continue something that we used to do many months ago, a couple of years ago, I guess. That is a series called 5 by 5. Now, when we did this earlier, we weren't really sure that how we were supposed to do this, and unfortunately, the five topics that you used to present in one session used to be like too much. So I decided to change things up a bit by looking at only minor emergencies. So we are going to discuss five minor emergencies today, and basically by minor I mean things that need emergency department evaluation and treatment, but doesn't really need to come in via ambulance or anything. So before we start, one book that I would definitely want everyone to read if they are interested. That is called a book Minor Emergencies. So I think the latest edition is the third edition. And frankly, this is one of the best medical books that you'll ever read because it's looking into some very, very commonly seen conditions that are unfortunately not gone into much detail when you look at the major textbooks. So they often, gloss over these kind of things. And unfortunately, these minor emergencies are very common. You see them every day in the emergency. So it is a good idea to have some idea about how to approach these problems. So without further delay, we'll go into the first scenario. So 32-year-old male patient comes to your ED with this kind of posturing of the neck. So there is hyperextension and lateral deviation of the neck and is protruding the tongue and there's some upward gaze deviation. He has history of some psychiatric illness and yesterday he was given some haloperidol. So what do you think this diagnosis is? You can type it out in the chat box. So what do you think this condition is? Yeah, it's acute dystonia. So what do you want to do for this condition? What would you like to do for this condition, acute dystonia? Yes, you are diagnosed it correctly. Okay, we'll get into that. So, somebody said something. Ben Stopin, yes, very good, very good. That's definitely what you should do if you have that available. So it's not really uncommon. You will see this eventually in your career if you do use neuroleptic medications, and we have a lot of medications with these kinds of properties in all levels of your healthcare system, not just at tertiary hospitals. So the thing that you have to understand here is this is an idiosyncratic condition. So it's not related to drug overdose or anything, and it's important to keep in mind because sometimes people might get upset when your patient develops this condition. So remember that it's idiosyncratic and there's not much you can do about it. So usually it's the facial and neck muscles that are usually about jaw, tongue, lip, throat, etc. And classically, you have your hyperextension and lateral deviation of the neck. So like we've seen here in this image. So the commonly associated medications are your chlorpromazine, haloperidol, prochlorperazine, promethazine, and metoclopramide. So these some of these medications are very very commonly used in all levels of your healthcare system. So there are different types of the this thing. So a lot of different variations of this acute dystonia can come. So usually it occurs very quickly within a few minutes or hours, but if you're using something like haloperidol, the presentation can be delayed by even up to 24 hours. So some people are at increased risk of this condition. For example, it's more common in younger male patients, and if you have a history of alcohol or cocaine use, or if you have a family history of dystonia, then you are at increased risk of a dystonic drug reaction. So your DDs are importantly things like partial seizure and tetanus. So all of those things, tetanus can also cause this weird stuff to have happen with your neck muscles and all. So those are other things that you should keep in mind. Meningitis, psychosis, etc. These are also things you should keep in mind when you're seeing this condition. Again, how you'll differentiate is obviously going to be combining it with your history and all. So the management that you have to remember is you give either IV benztropine or IV diphenhydramine. And what you should not do here is to give IV benzodiazepine, because it will get better with IV benzodiazepine. But the thing is that IV benzodiazepine is also good for other conditions on this differential diagnosis. So you will not be able to be sure whether what you actually treated is acute dystonia or one of or some of these differential diagnoses. But if you give IV benztropine or IV diphenhydramine and the patient gets better within the next few minutes, and usually the treatment symptoms will completely resolve within about 15 minutes, then you have both treated and you have diagnosed the problem. So that's the great thing about this thing. It is both therapeutic as well as diagnostic. So that is the basic 2 3 points that you have to remember about this condition. So other things you have to do is you obviously discontinue the offending medication. If the patient is on this medication long term, you might want to have a discussion with your primary treating team to discuss about adjusting the dose or changing to another medication. If you have a longer acting medication, which is a culprit, maybe you need to give one of these medications orally for a couple of days to prevent a relapse. So if the patient is having a very typical presentation, you don't need an extensive diagnostic workup. And but if you are not getting a usual response to treatment, you have to consider the differential diagnosis. So if you're not having good response to treatment, you have to consider that something else is actually going on. And again, don't use benzodiazepine first, because it will relax the muscle spasm from other conditions as well, and you will be left with a lot of diagnostic uncertainty. That was the first problem. Now we are moving on to case scenario number two. You have a young lady coming with acute onset of anxiety, breathlessness, tingling. She says she has having some tingling sensation around her mouth and fingers. She's having some similar attacks in the past, and she has been having trouble as she's preparing for an exam in the coming month. So you examine her clinically, and other than tachypnea, doesn't appear to be much wrong with her. So what is this young woman having? Yeah, so she's basically having a panic attack, and if you want a more fancy term for that, you can call it the psychogenic hyperventilation syndrome. So you have acute onset anxiety, breathlessness, palpitation, chest discomfort, abdominal discomfort, tingling sensations. Often it might be associated with some kind of psychological trigger. This is extremely common. Every person, every intern, everyone has seen this issue at one point or another when they were working in the emergency. So a physical exam increase respiratory rate. If it is like really severe, patient might have transient periods of apnea in between as the patient actually tries to normalize the PCO2, because the PCO2 in this condition can actually become really low if it is severe. The rest of the physical exam is normal, and if really severe alkalosis can lead to hypocalcemia, and corpus spasm can also occur in severe cases. Things to keep in mind, obviously. So what to do is obviously very important. You have to rule out more serious cardiorespiratory causes of tachypnea. So don't assume that this is the diagnosis. Always this psychogenic hyperventilation syndrome or panic attacks are going to be a diagnosis of exclusion. So you have to have a high index of suspicion for other usual causes that caused tachypnea in the ED. So, and at least you have to get an SpO2 done. You make sure that the patient is not actually, having a low SpO2. Make sure the vital signs are all normal. If they are not normal, you have to start suspecting that something else is actually going on. The management, you have to basically is reassurance only. So what used to be recommended once upon a time, and what people might have seen in a lot of movies and all, is that people will be asked to breathe into a bag that is no longer recommended. So what you can do instead is to provide some length of tubing that you see here in this image, through which the patient can breathe, and slowly the symptom should resolve. Alternately, you can use some kind of reservoir with oxygen. Why is a paper bag no longer recommended? It's because that can lead to hypoxia. So that's no longer recommended. So basically, what we're trying to do is to basically make the patient breathe in a little more CO2. That will help them increase your PPCO2 levels and normalize their symptoms. So management is that only. Can you give some sedative? You can. If the patient is like really distressed and all, you can consider low doses of lorazepam, or you can use, the thing that people use when they're too afraid to use benzodiazepine, which is Atrax or hydroxyzine. So if these symptoms are not reversed within 15 to 20 minutes, if what you think is a panic attack is not resolving within around 20 minutes, then you have to really start thinking about something else is actually going on. And in that case, you actually start doing a more detailed investigation, at least get a blood gas to see what is going on. And once the patient symptoms resolve, you go tell them to go for a long-term follow-up with psychiatry. So again, these are not very complicated problems, but you have one or two tricks that you have to remember. So basically, you don't make them breathe into a bag. You have to give them some kind of tubing like this, or any kind of reservoir bag with oxygen to breathe into. What not to do is obviously to miss any deadly causes of tachypnea. Don't make them breathe into a paper bag. And again, you don't need to go do an extensive evaluation for all of these patients if the presentation is very typical. So that is about case scenario number 2. Now we are going to case scenario number 3. So a 22-year-old lady is brought to the emergency department with complaints of altered sensorium, and she had a recent altercation with somebody at her home, and after that she became having some abnormal behavior. You noted that patient is having some bizarre posturing. She's turning her head left and right, and she's having some pelvic thrusting movement. So, and you also note that in between this episode, she's having a rapid regain of consciousness in between. So, what do you think this diagnosis is? You can mention it in the chat box. So, what do you think the scenario is basically? It, not really delirium, not tremors. Yes, it's PNES. PNES. This is PNES basically. Psychogenic non-epileptiform seizures, sometimes called functional seizures. It used to be called pseudo seizure. That term usually isn't used that commonly anymore. So usually these patients have a history of recent emotional upset. That is one thing. One thing that I would like to stress here is that these patients will have some kind of serious problem going on at home. So it is not your job in the emergency department to start judging them and trying to cause them some more trauma in the ED. You should have an empathetic approach to this patient, because there can be a history of sexual abuse in these patients. They might be having some depression, substance abuse, anxiety, personality disorders, eating disorders, etc. So be kind to these patients if nothing else. So don't be judgmental. Don't think that they are purposefully wasting your time, because oftentimes these patients are not in control of what is actually happening from them. These patients are not malingering. They actually do think that there is something seriously wrong with them. So again, since this is associated with sexual abuse and all, you won't be surprised that it is actually more common in females. So it is an unconscious manifestation of psychosocial distress that the patient cannot control. Again, patient cannot control this. So again, you will have bizarre posturing, dramatic thrashing with prolonged seizure-like movements. So typical findings are when patients are turning their head from side to side and there's some pelvic thrusting going on. Usually we don't see that with typical seizures. And again, unlike typical seizure, consciousness is usually recovered very quickly after the supposed seizure episode. So what are some clues on the exam that can help you, clinch the diagnosis here? Usually the patient should not usually, the patient should not have any focal neurological deficit. If they do, the diagnosis is not PNES. And patient with true seizures, usually when they are having true seizures, they will actually have abdominal contractions, but they will lack corneal reflexes. Whereas in a patient with pseudo seizures, usually they will have intact corneal reflexes, but they won't have the abdominal contraction. That is one trick that you can look for. Generally, with true seizures, patients' eyes will generally be open, but in pseudo seizures, generally they'll be firmly closed shut. So, and similarly, patient with pseudo seizure, they'll be resisting eye opening as well. When they are open, you can have rapid or saccadic eye movements that generally is more seen with PNES, whereas slow roving eye movements, those patients generally really do have a depressed level of consciousness from some organic disorder. So again, another thing is a tearfulness during the event argues against a true seizure. And generally, with pseudo seizure, there should not be fecal urinary incontinence. Generally, they will not have any severe injuries to the self. And lateral tongue biting, again, not typical of PNES. Tip of the tongue biting might be seen in PNES rarely, but lateral tongue biting, which is that is almost exclusively seen with true seizures. So again, you will examine the patient like you do with any other patient that you comes in the emergency department. Always check a blood sugar. You do not want to miss some kind of hypoglycemia and all in these patients, for PNES and all. So if a patient is having severe agitation, severe psychological distress, and again you can consider the same things we described earlier. So hydroxyzine or lorazepam. So VBG can be useful in these conditions. Why? Because an elevated lactate can rule in true seizures. Why? Because PNES and true seizures can exist in the same patient. So I remember there was one case we saw maybe a couple of years ago when patient came to the emergency. Patient had a seizure inside the emergency, which is Pakka GTCS, but patient was under evaluation and basically was diagnosed with PNES. So then the neurologist was not convinced because all the diagnostic workup earlier was suggestive of PNES and all, and they didn't actually believe that we actually saw a true seizure, and then we did a VBG and showed a lactate of 12. So you can fake a lot of things, but you cannot fake a lactate of 12 after an episode like that. So that was basically a true seizure in a patient who was actually being evaluated for pseudo seizure. So that can also happen. So you can always keep in mind that PNES and true seizures can exist in the same patient. So a VBG can be useful. And again, you'll generally have to keep these patients in the ED for a little while. If the patient is not awake, alert, and oriented after about 190 minutes, you have to do a more comprehensive workup. Do you need a comprehensive workup in each and every patient who presents with typical PNES in the ED? No, because that's generally going to be a waste of resources in a high volume center. But if the patient is not, normal within about 90 minutes, you have to start thinking about other things, and you have to do a more comprehensive workup. That is a good rule of thumb to keep in mind. So DDs, important thing that you have to remember, again, true seizure often can coexist. Syncope, important thing that can be very similar to pseudo seizure is something called hypermotor frontal lobe seizures. So these can present with some very bizarre movements, movements that we generally don't associate with seizures. So it can look like pseudo seizure, but a couple of clues that can tip you off is one thing is that these can be very brief, and these almost exclusively happen during sleeping. So that is one way that you can differentiate the pseudo seizures from the frontal lobe epilepsy and all. And the other things are usually less likely, but again, things to keep in my mind, like toxin, dysarrhythmia, and all. I remember one case I didn't see, but actually one of my seniors was seeing, and the patient was initially it looked like some PNES pattern, but eventually the patient ended up having carbon monoxide poisoning. So again, it's a good reminder that PNES, like all other things, should be a diagnosis of exclusion. And you should have a low threshold for looking for other conditions. If the presentation is not typical. So again, very important. Don't get angry with the patient. Don't torture the patient. Don't start putting in rails tubes or all these other things to try to pick the patient up or anything. Don't administer anticonvulsant. Don't send the patient home on phenytoin or anything. That is not required. And do not perform expensive workups, at least from the ED perspective. Maybe on the OPD basis, you might consider doing an MRI or a, EEG or a video EEG to actually rule out other conditions. But in the ED, these things are generally not required. And if the patient is not fully recovering within 90 minutes, again, you should start, actually suspecting that something else is going on. So that was scenario number 3. Scenario number 4. So yeah, 46-year-old gentleman. This is basically a visual diagnosis. What is his diagnosis? He's having facial weakness since the past couple of days. You can type it out. Visual diagnosis. What is the image telling you? Yeah, this is LM facial palsy. So how do you differentiate between LM and human facial palsy? Usually, human facial palsy, the upper part of the face will be spared. In element facial palsy, the entire face will be involved. That is the big important differentiating factor between both of these things. So the question is what do you need to do for these patients in the emergency department? So usually Bell's palsy builds up gradually over a couple of days. So usually it reaches maximum severity within 48 to 72 hours. Whereas in a stroke, usually reaches about maximum onset instantaneously. That is another differentiating point other than the, obviously difference in distribution of weakness within the human and element. The onset is also another differentiating factor between the both of them. So other things that can, make you suspect that something else might be at play. If the patient is having some weakness, gross weakness, as along with the facial nerve palsy, again, that isn't typical of Bell's palsy. Bell's palsy shouldn't be having any limb weakness that moves the diagnosis into some acute brainstem pathology. Vision changes, again, not usually seen in Bell's palsy. Lyme disease not really something you consider in India. Autoimmune disorder, severe immunocompromised states. You have to be careful about some kind of intracranial pathologies, and obviously trauma. Again, you don't treat that as Bell's palsy. That is something else. So differential is usually stroke, trauma. These are the things that an infection. These are the things that you generally will consider in the ED. Neoplasm is generally going to be worked up more on an OPD basis, not really something that you are going to be able to work up in the ED in most of the time. So these are some red flags for Bell's palsy that you should know in general. For example, this is not just for ED. For example, no improvement within 3 months. Usually should start improving within 3 months. Actually, 90% of the cases. If not, then you start considering other things and all. But again, not all of these are considerations in the ED. What I care about in the ED is whether I need to get a CT scan or not. So when do I consider getting a CT scan? Number one, if the patient is having any history of trauma, then obviously I need to get a CT scan, look for things like temporal bone fractures and all. Atypical presentation, anything other than the usual presentation of a Bell's palsy, you get a CT scan done. So that is one thing. Any neurological signs, if any focal neurological deficits, CT scan. Vertigo, CT scan. Severe headache, CT scan. So all of these things are indication for getting a CT scan done in the emergency department. Other than that, usual typical garden variety Bell's palsy, you do not need to go for imaging. You can just treat the patient without imaging also. Although this can differ based on your institution protocol, but in general, you don't need to get imaging done. Management usually involves three important things. Number one, steroids. Number two, antivirals. Number three is protecting the eye. So number one is steroids. Steroids you start with prednisolone, 60 milligram OD for 7 days Do you taper? Do you not taper? Controversial. Depends on what the people in your institution likes to do, basically. So in our center, we do do a slow taper of steroids in Bell's palsy. Some resources say that may not be necessary. So it depends. Antivirals, you can go for acyclovir for 10 days or valacyclovir for 7 days. Obviously, valacyclovir is going to be much more better tolerated for most patients, because anybody who's had chickenpox and taken acyclovir will know that taking that medication 5 times a day is easier said than done. Most importantly is protecting the eye, and often I think people miss this as well. Artificial teardrops are important, and make sure that you cover the eye at night, because that is a main problem for this patient, because uh, these patients are not able to close this eye properly, so that can lead to all kinds of mechanical trauma to the eye. So you want to prevent that until the patient can recover fully. So one important caveat that you should remember here is that there's something called Ramsay-Hunt syndrome, and this is something that you should be looking for whenever you are suspecting Bell's palsy. Why? Because it can change management. So basically, there is involvement of the genicular ganglion as a consequence of VCV infection, and basically it will present like with facial palsy with the added feature of vesicles near the ear and their external auditory canal. So you have vesicles here. Why is it important that these patients may need IV medication and generally has a poorer prognosis, with only 10% recovering with normal function, whereas in Bell's palsy it's usually the reverse, with 90% usually recovering fully in about a month and a half or so. But make sure that you do a good ear examination this patient, and make sure that you're not missing the Ramsay-Hunt syndrome, because that might need an admission. Otherwise, this can be treated in OPD basis. So that is all about Bell's palsy. So Bell's palsy, important things is not to miss stroke, not to miss trauma, and to not miss examining the ear. So we are moving on to the final scenario. That is scenario number 5. So you have a 24-year-old male patient who was actually accompanied his friend to the ED. He was having some fever or something. So his friend was having his samples taken, and after seeing his friend's samples taken, this guy suddenly had uprolling of eyes and fell unconscious. But after he lie down for some time, there was a rapid regain of consciousness, and he was fully not normal on the exam. So what is this? So this is something that we have all seen. Every medical student has seen this in first year MBBS cadaver lab. Uh, at least one or two of your friends must have had this. That is vasovagal syncope. Very, very common. So there are different types of reflex syncopes, a few different versions of this. You have vasovagal syncope, situational syncope, and carotid sinus hypersensitivity. So vasovagal syncope is basically the situation we described. Situational syncope is where syncope happens in certain, particular situation, that cough syncope, micturition syncope, defecation syncope. Often very difficult to diagnose if they're coming with the first ever presentation. But if they give a history of repeated episodes after that particular activity, that is when you start considering that diagnosis. And carotid sinus hypersensitivity, if the patient is wearing a very tight tie or something, that can trigger syncope in such patients. But what you most commonly see is actually vasovagal syncope. And what is syncope as such? It is transient loss of consciousness due to global cerebral hyperperfusion. So a decreased blood flow to the brain leading to loss of consciousness that usually resolves by itself. That is why it's called transient. Often, syncope is mislabeled as other things which are not transient. You have loss of consciousness that doesn't resolve on arrival to the hospital. That is not syncope, that is something else. So you don't confuse syncope with some of the mimics like that. Usually, syncope is transient. So this is usually seen in young adults, and the usual sequence is some acute stressful event followed by relief of the stress. So what the exact mechanism is not very well understood. What is generally believed is that there is an increased sympathetic tone followed by decreased sympathetic tone, or there is increased parasympathetic tone. So basically, all of this leads to a combination of bradycardia and hypotension. So a sudden bradycardia and hypotension leading to sudden decrease in cardiac output, leading to sudden decrease of blood flow to the brain, leading to sudden loss of consciousness. So, what to do when you do when this happen? You can advise patients to actually, if they're usually they will be associated with some kind of prodromal symptoms. So when they are having these prodromal symptoms, you can ask the patient to lie down, or at least sit down somewhere to prevent some injury of while falling. So usually lying down for 5 to 10 minutes results in complete recovery. If the patient is not recovering after that also, then you have to start considering something more sinister might be at play. So if the patient had this episode outside the hospital, now he's coming here, so then the diagnosis becomes a little bit more complicated. If you're seeing the episode in the hospital, then it's a little bit easier to diagnose. But if the patient had this loss of consciousness outside the hospital, then regain consciousness, then are coming to the hospital. So then the differentiation is going to be first syncope versus seizure. And if it is syncope, then you have to differentiate between benign versus more serious causes of syncope. So the best thing to differentiate syncope from seizure is post-ictal confusion. Yes, you have other things like, urinary incontinence, fecal incontinence, tongue bite that are generally more commonly seen with seizure than syncope, but they can be seen rarely with syncope as well, because prolonged, hyperperfusion to the brain can lead to tonic-clonic movements as well. So sometimes the diagnosis can become difficult, but the most useful thing that is going to be post-ictal confusion. Rapid recovery consciousness within 5 to 10 minutes goes towards the diagnosis of syncope. Prolonged ictal confusion, 30 minutes or so, that favors the diagnosis of seizure. So always also consider something like possible, hypovolemic status like vomiting, diarrhea, and all that can also lead to these kinds of problems as well. Orthostatic hypotension, etc. So how to differentiate between benign and deadly causes of syncope? So everything is all about the history. So unfortunately, this is one place where there is no investigation that is actually going to help you. Everything is going to be based on your history. So first you start with baseline incidence rate. So if you're working in a PHC and lots of patients come to you with this problem, generally most causes of syncope are going to be benign. If you are working in AIMS emergency, which is a reference hospital, Apex hospital, we are going to see more of the deadly causes of syncope being referred here. So generally we have a bias that most of the syncope coming here is very, very serious. But if you look at syncope overall, majority of the causes of syncope are going to be benign only. It's just that we are an Apex institute, so we end up receiving a lot of the more deadly causes of syncope compared to the obviously benign causes. They're not going to be referred here. So generally, we'll have a prodrome. If the benign causes generally have a prodrome, nausea, diaphoresis, some lightheadedness before it actually happened. If there is a prodrome, then that is generally a good sign. That means it's not it is more likely to be a benign causes of syncope. Things that are bad are non-exertional syncope. So patient was, sitting or, sitting somewhere and had syncope, that is bad. Syncope while supine, very bad. That is definitely something serious is going on. Patient with a history of heart disease on some QTC prolonged medication, then they are very likely to be having some kind of arrhythmia leading to syncope. Again, very, very bad. Always do a good CNS exam, look for any focal neurological deficits, and always also do a CUS exam, looking for murmurs of specifically aortic stenosis or hypertrophic cardiomyopathy. So these are things that you can consider. So investigation, the only investigation that you have to do in all patients is an ECG. All syncope patients get an ECG. You don't need to do anything else in most patient, but an ECG is a must. UPT in the females of the reproductive age group, remember, ectopic can be a cause of syncope or like syncope-like presentation. So you have to keep that in mind. So blood test generally useless. So if you are suspected some kind of occult bleeding, then you can consider doing a CBC. Otherwise, blood tests are not going to help one bit in syncope. And CNS imaging only if you are suspecting some trauma or true seizure-like activity, or the patient is having focal neurological deficits. Now, CNS causes of syncope do occur, but they are generally only consider once you rule out the common things and the cardiac causes. Only then will you charge considering the CNS causes of syncope, and generally that is not going to be considered in the ED at all. So, CT head generally no. So when do you consider patient to be admitted rather than discharged? Patient is having some obvious heart disease, heart failure, some arrhythmias, so don't discharge them. ACS, pulmonary embolism, aortic dissection, there are serious causes of syncope, but they very rarely cause syncope, and syncope is very rarely caused by these disorders. But again, something to keep in the back of your mind that these things can occur. So you should keep those in mind, especially in something feels off. And if the exams suggest a significant valvular heart disease, you may consider admission. So, but it depends on the hospital you are working at, and especially on the ECG is showing ischemia, arrhythmia, and all, and then you have to consider admission, or at least if you have significant valvular heart disease or any specific pathologies associated with syncope, at least consider a very quick follow up with cardiology if they are sending them to the OPD. Some things you can look for on the ECG, for example, WPW syndrome. You can see some delta waves here, most obviously in V2, V2, V3. These are some specific things that you look for in syncope patients. This is a case with hypertrophic cardiomyopathy. You can see some very narrow Q waves lead seen in the lateral leads V5 V6. You can see some more bigger R wave in V1 than you usually see. So these are something that can point you towards the patient may be having a diagnosis of hypertrophic cardiomyopathy. And this is Brugada syndrome. You can see the RBBB-like pattern associated with an escalation ending up in a T wave inversion in V1 to V2. So this is makes you think of Brugada syndrome if the patient is presenting with syncope. Usually presents with syncope in arrhythmias in sleep. And this is a patient with a prolonged QT interval. Again, something that you should not never miss in a patient with syncope. So how do you estimate whether a QT is prolonged without actually calculating the QT? You compare the QT interval with the patient's RR interval. If the QT interval is more than half of the RR interval, then that QT interval is prolonged, and this is definitely much more than half of the RR interval in this particular ECG. So this is called prolonged QT interval in a patient with syncope. So another things you can make you feel uncomfortable while managing a patient with syncope. Elderly patient with syncope, generally that's not good. Whereas if you are a young person with vasovagal syncope, that is obviously a good thing. But in elderly patients, we must be very careful while evaluating them. History of coronary artery disease, history of congenital heart disease, family history of any unexpected sudden cardiac death, exertional syncope in young patient without any other obvious causes. Patient is complaining of shortness of breath, a hematocrit is less than 30, a systolic blood pressure less than 90. So obviously, if these things are there, the patient should be admitted. They are not going to be discharged. So remember, especially the last three things: shortness of breath, hematocrit less than 30, and the SPP less than 90. These are things you should remember. So coming back to vasovagal syncope. So again, this reassurance and explain about need to recognize a prodrome and lie down to avoid fainting. If the patients have a recurrent episode, then you might need to have conversations about, restricting the patient from, unprotected driving, swimming, diving, etc. Because, those are situations where, having a syncopal episode can actually be deadly. So how to prevent, vasovagal syncope in the ED? Do not allow family members you to stand while receiving bad news if possible. So you're trying to explain some bad news. It is good practice to offer them a seat. Do not allow parents to stand while watching their children being sutured or something that they can get syncope just watching that. And do not allow patients to stand while being giving injections or while doing venipuncture, etc. So, so again, what not to do? So don't obtain CT scan unnecessarily. Most of the time, it's not necessary. Similarly, with EEG studies, most of the time it's not necessary. Blood tests usually not necessary. So usually in vasovagal syncope, you don't need detailed any kind of testing, even table testing. Most of the patient is not required. But you should not discharge patients quickly with who are having these risk factors that we explained earlier on. So these patients they are the exception where you should not be discharging the patients. So these are the conditions that we discussed today. Not very complicated condition, but these are things that we do see very commonly in the ED day in day out, and often we are really not quite sure on exactly how to approach them. So I hope the this lecture gave a few tips on how to work up and treat some of these patients.